And so thank you all for joining us for Youth Suicide Prevention, Recognizing and Responding to Students at Risk. This is the last webinar in our student support series for this school year. So thank you so much for joining us. And I am already starting to plan for next year, so keep an eye out for that information. So as most of you know, my name is Kate Bohannon. I'm a consultant with the State Department of Education. And big thank you to CERC, who is providing our tech support today. Cameras and microphones are disabled. We have a large group here. So please use the chat for comments and the Q&A for questions, just so the questions don't get lost in the shuffle. The webinar is being recorded and the slides will be shared with you all. The recording will also be up on the student support playlist on YouTube. If you're having technical issues, you can send a chat to CERC. If you're in the webinar, if you get booted and having trouble get back in, please send Linda Adorno an email. This webinar has been approved for 1.5 continuing education credits. You can see the criteria there below. You must be an employee of a public school district, attend at least 15, or excuse me, at least, miss no more than 15 minutes of the webinar, and complete the CEC request form. Every time I get a couple questions about this, so all request forms are processed after the deadline closes. So the deadline closes June 5th. You can expect to receive your certificates the week after. Um, Again, I like to situate us in who we are and who we're here for. So these are some demographics from the 24-25 school year about our students, our school districts, and our school mental health staff. I just want to have a brief reminder to take care of yourself during this webinar. We are talking about suicide and youth suicide, and that can be a really heavy topic. So please make sure that you are being mindful of this as you continue your day, and to reach out to supports if you need to. Utilize your EAP programs at your school. You may also call Adult Mobile Crisis. It's not only for a crisis, but if you need someone to talk to or connection to services, they can always be of assistance with that as well. So we're going to get into some data here. So from the 2025 Connecticut School Health Survey, also known as the Youth Risk Behavior Survey, they ask questions of high school students about a range of topics, including mental health. And so out of this cohort from the 2025 survey, 30% of students felt sad or hopeless. 21.1 said that their mental health was most of the time or always not good. 12% seriously considered attempting suicide, and 5.7% of students actually attempted at least one suicide. And this is all for the time period of 12 months before they completed their survey. And this statistic always breaks my heart a little bit, that only 21% of students reported that most of the time or always they got the kind of help they needed. And that's a tough statistic to sit with. And I know that we're all doing what we can. And hopefully this webinar and other opportunities that we've presented can help to close that gap and make sure that our students are getting the help that they need. So looking at statistics specifically about youth suicide, this information is from the Office of the Child Advocate. They put together these graphics, and the Office of the Child Advocate investigates any untimely death of a youth under the age of 18. So you can see on the top corner there, this is the suicides by age and year from 2021 until last year. So there were 13 youth suicide deaths in 2025. We don't have the 2026 data up yet because some of those deaths are still being investigated. But in the last week alone, we had 3 suspected suicide of youth under the age of 18. We've also had 3 deaths due to suspected Benadryl overdose in the last 6 weeks. We include that there just as a reminder that when you're talking with families, to think about their medicine cabinets when they're thinking about access to lethal means. And it's not always prescription medications, it's things that are available over the counter. We do have a link here, and I'm going to put it in the chat as well. We recommend that you contact your local health department. Oftentimes they have access to medication disposal bags and potentially lock boxes as well. So that's just something to keep in mind. You can see below as well information about the sex, the race and ethnicity, and the cause of death for our youth suicides. So now I'm going to move on to our two presenters. So we have all this information and what do we do with it? So how do we help students that we're worried about? And so I'm so thankful that we have this great team here today. We have Dr. Steve Rogers from Connecticut Children's. He's the medical director for the Youth Suicide Prevention Center, amongst many other titles that would not probably fit on this page. And also Kristen Volz-Spessard, who is the program specialist for the Youth Suicide Prevention Center at Connecticut Children's. Later on in the presentation, we will hear from Emily from Mobile Crisis and also Amy Samela about the Urgent Crisis Centers. So, Kristen, I'm going to turn it over to you now. I'm also going to share in the chat the link to the slides if you'd like to follow along, as well as the link to the local health centers or health districts.
Thank you, Kate. Just to check, you can see my slides all right.
Looks good.
All right, awesome. Go ahead and kick it off, Steve.
Good morning, everyone. Thanks for being here. We appreciate your attention to helping to prevent suicide deaths among youth, and we hope this is helpful in your daily practice. Next slide. There we go. So to start, we're just going to quickly read off the learning objectives for today's talk. We hope you leave this presentation understanding the prevalence of suicide in Connecticut through a review of current data points. We want to recognize and define examples of suicide clues and warning signs and how these signs may present differently based on factors such as age, culture, and religious background. And we will be utilizing some of your expertise to help summarize and put this together, because there's not really any specific resources for that. We're going to develop a familiarity with some of the basic prevention strategies and explore how they can be implemented using screening tools, trainings, and suicide prevention programs such as our own, and then understand the continuum of crisis support available in Connecticut, which we are lucky to have and is very rich with amazing services, including when it is appropriate to utilize mobile crisis, the suicide crisis hotline such as 988 and the urgent crisis centers, as well as the emergency department. And finally, identify available resources and supports to strengthen your school's communities' suicide prevention efforts. And we think we have some good additions to some of that will help you guys. Put the camera back on so I can read. Next slide. So the CDC publishes annual just fatality reviews. And they publish these sort of standard charts that show us the top 10 causes of death by age group. This data is from 2024, so it's the most recent. Next slide. Across the top, you'll notice that the age ranges. So it's like 0 to 1, 1 to 4, 5 to 9. But starting at and then down the side are the causes of death. Next slide shows that in the age ranges of 10 all the way through to 34, so 10 to 14, 15 to 20 something, and then shows the top 3 causes of death in this box. And you'll notice the 3 boxes that are green are all suicide deaths. So it's the second leading cause of death in our country amongst 10 to 14-year-olds, and then continuing all the way through to the age of 34. And we would argue that those suicide deaths in their 20s and early 30s are likely due to unresolved issues from teen years. Next. The other source, which we've already heard briefly about, is the Youth Risk Behavior Surveillance System. It's just an amazing resource. And when students are answering anonymous questions and have dedicated time to do it, and these are very well-formed, well-seasoned questionnaires, we really get a chance to kind of peer into the minds of youth. And it does cover all sorts of things like drug use and drinking and driving and unprotected sex and all sorts of risky behaviors. But the questions specific for suicide are really concerning because of the rates and responses. Next slide. So one of the big ones is the percentage of high school students who seriously considered attempting suicide. And this is Connecticut specific. So next slide. Oh, I'm sorry. Actually, it's not. This is the national ones. That's right. We already did the Connecticut ones. So nationally, I'm just getting you guys to sort of get your brains rolling. Hopefully, you have your coffee going too. Uh, just think in your heads, how many kids out of, let's say, 5 uh, have seriously considered attempting suicide in the past year? Next slide. We can go forward, Chris. There you go. So it's about 1 in 5. So 20% of kids. I mean, that's to me frightening, right? That 1 in 5 high school kids have seriously thought about killing themselves in the past year. That's a lot of kids. Next slide. So when we talk about suicide deaths, we're really talking about a very small tip of a very large iceberg of kids who are suffering with thoughts of suicide. So how many of those kids actually even attempted? Now I'll pause for a sec. A lot of my pediatric colleagues will often question me on this next result. And they say, what do they really mean by an attempt? What did they actually do? Because the numbers are so great. And my answer is, who cares? If a child or adolescent reports that they attempted suicide, they felt like they did something, they moved towards the knife, they thought about jumping off the bridge, they did any of that, to me, we've missed the mark, right? And we've missed the opportunity to capture that child and provide them with the care that they need. So out of 10 kids, how many do you think thought about or actually attempted suicide in the past year? Next. It's about 1 in 10. That's a lot of kids. Too many. Next. So our answer, universal screening. That's our best tool in our clinical environment. I would imagine it would be a very powerful tool in the school environment, allowing you to reach all of your students potentially, or most, and doing it in a as scientific and effective way as possible. We started universal screening here at Connecticut Children's in our ER, and now do it in our inpatient units about 5 years ago. And it's been a very telling journey. Speaking of data, next slide. So we started because we had to. We didn't have to universally screen. Our Joint Commission, which is our kind of our standardizing body, that accrediting body, I should say, that allows us to bill Medicaid, actually, is able to set standards and national patient safety goals that we have to follow. And so they said that you have to screen all kids that for suicide risk. And then they said, well, we really just meant behavioral health kids. And I know I'm speaking to the choir here, and I'm sure that makes no sense to any of you, because if all we screened was mental health kids, then we would never discover the kids who don't have mental health problems, who are suicidal, and those are likely the hardest ones to identify. So we started screening universally. We also have the American Academy of Pediatrics that recommends screening. Both bodies recommend screening 12 and older. We do not. We recommend 10 at a minimum. Next slide. And that's all based on the data we just went over. Very coincidentally, not coincidentally, I should say, we had an expert consensus pathway that was published at the time of this requirement that helped people follow a workflow that was expert consensus based, and we took that workflow and modified it. And the reason I talk about the workflow, next slide, is in order to have a successful screening program, you really have to have the response planned out. So you can't just say, hey, let's start screening kids in class, or let's start screening kids that come to the counseling office, and then we'll figure it out if they're positive. You really got to have this planned out so that you're efficient, you're safe, and you're consistent across your institution. This is how we do our workflow. Next slide. Basically, we have our nursing staff screen all kids 10 and older with the ASQ screener. That's the Ask Suicide Questions screener. Next slide. Which is featured here. 4 simple questions, takes 30 seconds. There's a 5th question if they say yes to any of the first 4. It is very well validated, has had multiple publications showing its effectiveness, and they're actually going to modify it sometime soon too to improve it even more. It comes with a toolkit in a sense, which really gives you scripting on how to use it, how to respond to people when they answer. It doesn't have to be you as the counselor. It could actually be another staff member that can screen these patients as well. So that the burden of asking doesn't always have to be on you as busy clinicians. They can even answer it on paper. They can answer it on their phone. You can do it pretty much anywhere. But it's an excellent screener. It's simple. It's easy for them to read. And you'll notice it doesn't actually even use the word suicide, so that there's less cultural bias involved in screening. Next slide. So we believe this is evidence that it is feasible. Even in our busy clinical ED environment, we have a 90+% compliance rate by our nursing staff, meaning that our nurses not only have changed the culture within our ED to make this a norm, but they continue to do it at exceedingly high rates. A real good quality program, improvement program in an ED would shoot for about 60 or 70% compliance, and we are consistently above 90% now. And that's really because of, like I said, culture change and the fact that it's simple, and we've made the workflow very standard and easy to follow. Next slide. So this is our results. These are also kind of shocking in my opinion. We have about an 18% positive rate. I guess not shocking in the sense that it really matches up pretty well with the YRBS data we discussed earlier. So we would expect high school age kids, even adding in 10 and 11-year-olds, to screen positive at about 1 in 5. We do have a disproportionate number of mental health patients that seek care in our ED, so that does inflate our numbers. And so if this was non-behavioral health patients, we'd expect about a third of that, so about 6,000 to 7,000 kids a year. Next slide. There was a big hesitation on screening 10 and 11-year-olds, including some of my colleagues who said, I'm not screening a 10-year-old. I have a 10-year-old, and I would never ask my own child those questions. Well, you should, because in our first year, we had 160 10 and 11-year-olds, actually just 10-year-olds, sorry, that screened positive, and 60 of them, so a little less than half, had reported a suicide attempt in the past year. So it's happening. As again, I have to keep reminding myself I'm preaching to the choir. You guys are all experts, but a lot of our parents and staff and others think, oh, I don't want to plant the seeds of suicide, but we know asking suicide questions is actually protective, and talking about suicide with somebody who may be suicidal is protective. And we don't plant the seeds of suicides when we talk about it. We identify ourselves as a source of help and a source of understanding and a source of hope. So we had I'll pause for a very quick story. In our first month of screening, we had a 11-year-old little girl, and I specifically say a little girl, as many 10 and 11-year-olds are still very small, little kids in 5th and 6th grade, who screened positive. My provider colleague was not happy about having to go in and do a secondary screener, which is what we do. We do a secondary screener with the Columbia, and we risk assess. She went into the room, kind of gave me a hard time as she went in, saying, this is all your fault that I have to do this. And I laughed because she was half joking, but half upset about it. And she came out, got the mom, and she then went back in, came back out, and said to me, don't talk to me, just read my note. And she detailed in her note exactly what happened in that interaction, which was mom came in, she informed the mom of the suicide risk of her child. The mom turned to the child and said, sweetheart, this can't be true, is it? And the little girl said, yeah, mommy, it is, it's true. And the mom said, but I thought we were best friends. And the little girl said, well, of course we are. And she said, but best friends tell each other everything. And the little girl said, well, yeah, we do. And the mom said, but you never told me. And the little girl just looked at her and said, but you never asked, mommy. So just gets to me, actually chokes me up every time I tell a story, because we have to ask, right? Suicide's a tough thought. It's something hard to think about. And when you're 10 or 11 years old, you probably think you're having bad thoughts. and nobody wants to be a bad child. Uh, so sorry if I'm choking others up too, but that's kind of the point. We have to ask because our parents aren't going to always ask, right? It's a hard thing to talk about, especially if you're carrying grief, PTSD from your own experiences as an adult, and so you may be really hesitant to talk about it. And so we have to offer ourselves as an opportunity for kids to be screened. So even if they don't say yes the first time they're screened, they may. Then I know for a fact because we get it in the ED, kids will come back with somatic complaints like belly pain or headaches, and all of a sudden they're positive on their suicide screen when they weren't previously. And they'll even admit, like, yeah, I've been having these thoughts and it's really bothering me. And that's why I'm getting headaches and that's why my belly hurts and I'm really anxious and nervous. Next slide. So this is our the rest of our pathway. Like I said earlier, we use a secondary screener. I don't think that is absolutely necessary for you guys as healthcare professionals, mental healthcare professionals. You may have your own assessment tools that you use or something more detailed like the full Columbia, but we use the brief just because we're in a busy clinical environment. We want to make sure that we are using the best evidence-based tools as well as being consistent and as objective as possible. None of us are mental health care professionals. We are medical healthcare professionals. So we're trying to rely on tools to do it better. Next slide. That is the Columbia, sorry. And that'll be in the PowerPoint if you guys want to review the brief Columbia. It's a little more difficult to score. It's a little trickier to use, but has been very effective for us. And we are 90% compliant with that as well. And so it is also feasible. Next slide. This is the results of the Columbia. I put this up mostly just to show, if you look at the more recent years, the high-risk kids are in red, the moderate-risk kids are in orange, and the low-risk kids come back in yellow. You'll notice a pretty dramatic change over time. Now it's kind of like a third, a third, and a third. It used to be like a third, 10%, and 40%, whatever. I think I get those numbers wrong. But we will just say our opinion is that something happened way back at the beginning of this graph, aka the pandemic, that has now pushed lots of kids into that moderate risk group. And those kids are, a little tricky to manage, but not too much because most of them have historic risk, meaning they had some suicidal thoughts 2, 3, 4, 5 years ago when they were struggling. They're better now. But those are the kids that you guys would probably want to keep an eye on, right? Maybe that's a yearly check-in or every 6 months or whatever you think is necessary, but would be nice to identify so that you could be proactive and make sure that they're still getting the support they need due to the fact that they're increased risk based on some previous thoughts or ideation. Next slide. And the question of 10 and 11-year-olds always comes up. We looked at our evidence-based, so somewhere around 50,000 patients, and compared 10 and 11-year-olds to the 12 to 18-year-olds as recommended by national standards. And they're really not that different in a not so good way, meaning they're still at risk. They take longer to come back with their suicide attempts, but the demographics are pretty similar. Except they're slightly more low risk kids, which actually makes them easier to manage. So that's more of a, identifying the risk, talking to the family, setting up some services. But they're not as many 911 calls or 211 calls. So really probably not a significant increased work burden. Next slide.
All right, I will take over from here. Thank you, Steve, for showing our suicide screening data. I'm going to be talking about a couple of our other programs that we have here at our Youth Suicide Prevention Center at Connecticut Children's. So one opportunity that we have is our Question, Persuade, Refer training. Many of you may have already taken this training, and we thank you for that. The more people that are able to have these conversations, just like what Steve mentioned, we have to be the ones to ask. So the more people that you have trained and the more people that are comfortable in your community, you're creating a safety net of support. And for those who haven't taken QPR training before, it's a gatekeeper training. It's a bystander intervention training, very similar to CPR. And they actually name it very similar, very much the same because of people's awareness of CPR. So it positions you to recognize someone who's in a crisis and to identify the warning signs of suicide risk. And anyone can take this training. So that's why we really emphasize that anyone in the community can do this. Anyone can have those conversations in order to save a life. So one of the aspects of our center is that we are always conducting research, we're always collecting data, and we were able to secure a research grant, which allowed for us to look at our QPR training that we have here at the center and share some outcomes with you all. So at this point in time, we've trained over 1,100 gatekeepers throughout the state of Connecticut. We have a number of gatekeepers who are in the healthcare field, as well as here at Connecticut Children's. And within our center, we also have a number of instructors too. We have 152 QPR gatekeepers who are Spanish speaking. And those who have used or reported using QPR since taking the course was a little over 269 at this point, which puts us in about 1 in 4 participants will use the skills they learned in QPR. So it really sets you up to be a gatekeeper and be the eyes and ears within your community. So talking about some clues and
Kristen,
warnings.
I'm sorry to interrupt. I just was looking at the Q&A and before we go into this, and I know Dr. Rogers may have to step out at some point, but there are some questions about screeners. I don't know if we can pick his brain really quick on
Oh,
these.
sure. Yeah, go ahead. Sorry,
S-
I can't
oh
see.
no, that's okay. So asking about the ASQ versus the Columbia, a lot of schools we did recommend using the Columbia, and my understanding is that the Columbia is normed for anyone to use. It doesn't have to be somebody with a clinical background. I'm not as familiar with the ASQ, so if you could speak a little bit about what the difference is with those two.
So we have found in our experience that the ASQ is just easier to use. It's quicker, easier, and you basically get 3 responses from it. They're either no risk, which is not really true, but we'll just say they're negative, they're at risk, or they're at high risk. So you get an acute response, a non-acute response, or a non-response. Having that high risk, low risk only category, I think might be more simple for somebody like a teacher to screen a child who's not a mental health care professional. And then it's kind of a simple response, which is, oh, wow, you're actually thinking about suicide right now. I need to act in a 911 fashion and get you to somebody now. Or you're non-acute, and that's somebody, I need to get you to our mental health care professional at the school, but not necessarily a 911 type response. The Columbia divides things up into low, moderate, and obviously negative, low, moderate, and high. So in our setting, that matches nicely because of the fact that we have variable levels of response available most times of the day. So, really depends on your capabilities within your school system, and then maybe even, being aware of how you function, maybe what's available in your school building, is really an important part. And that's why I try to emphasize that workflow. So you really have to kind of sit down and say, okay, who's going to screen and physically where? And then how would I want to respond? Do I want a teacher trying to think of 3 different potential responses, or do I just want to say, hey, if they're high risk, then just walk them down to the office right now. If they're not high risk, then call me and I'll come get them. And again, I'm sorry if I'm oversimplifying. that's where the ASQ, and the ASQ is simple for non-healthcare professionals to use, I believe, because their questions are so straightforward. The Columbia is a little more nuanced. They're both good tools. They both work really well. It just depends on what you're looking to do in terms of risk stratification. And so, yes, the Columbia is recommended. I have to say, I'm a little biased. The ASQ, I believe in my data and research mind, has a slightly stronger evidence base and validation process that went on with it. It doesn't mean that Columbia is any less effective. It just doesn't have as much of the data to back it up.
Thank you. And I just to my thought would be in a school setting, um, that it should be the school mental health professionals, school nurses, social workers, et cetera, who are doing the screening. If a teacher does have a concern, my recommendation would be that somebody from, this community here is probably better equipped to ask those questions and then know next
Yeah,
steps. And it, and someone also, there's a question here about in a school, who and when would you screen? And I would say anytime you have a concern. I don't know if Dr. Rogers, you have any thoughts on that, but my thought would be anytime you're worried about a student, it doesn't hurt to ask the questions, right? To your
totally.
vignette, that if you don't know if you don't ask.
Yep. Yeah. No, I mean, I think, I know there's hesitation to do universal screening. There's lots of uh, we'll call it just debate because you're going to have parents who don't want their kids screened. You're going to have, um, people who don't want to do the screener. I would say getting as close as you could to some type of universal screening at some type of pace that's feasible for your system would be great because there are so many kids that are not going to appear at risk and are not going to be discovered unless they're screened, right? Their behaviors are going to be fine. They're going to do their homework. They're going to show up at school. But it doesn't mean they're not suffering from suicide. So it's just, it's a very difficult thing to discover without asking. So, I imagine, there's some type of pace of students checking in with counseling. So maybe it's every time they come to the counselor, they get screened, or whatever pace works for you. But I would strongly consider trying to include as many kids as possible.
Okay,
Does
thank
that
you.
help?
And
Yep.
yes, I think
Oh,
so.
and
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 we'll have time. Yeah.
yeah, and Kristen, to add to you, I just wanted to throw out there. I know you were going back to QPR training. Um, it's something. Speaking of, that is a very good culture changer. So you can train your office staff, you can train your cafeteria staff, you can train anybody with QPR training, and it really does just kind of change the culture of your institution to one that is open to discussions and the idea of keeping an eye on each other and asking questions that are meaningful and helpful.
Thank you so much.
All right. So talking about clues and warning signs. So these are indicators that are observable for someone who may be at risk or considering suicide. So I wanted to provide you with a couple of examples here. So we have verbal clues, so what someone may say, a coded statement of intent. I always say the coded statements can be a little tricky, but I always say go with your gut. Someone says something that might sound off, you kind of get that sense of, like, I call them your spidey senses, and really take that as an opportunity to check in with them. Then we have situational clues, and situational clues, we think about the important or impactful events that may be disruptive in somebody's life. This can be like age appropriate milestones that others may have missed out on. I think of a lot during the pandemic when graduations were canceled. And that's a major milestone that many of us look forward to after completing those education steps. In addition to that, situational clues, I always think of in this way. We're wearing invisible backpacks. Every single one of us in this webinar room right now We all have an invisible backpack. Only we know what's in those backpacks. Only we can feel the weight of those impactful events on our shoulders. So you can't look at somebody and go, oh, you're thinking of suicide. So again, just emphasizing the fact that we all go through different life stages, we come from different places, different spaces, and we carry the weight of those events on our shoulders. Last one we have is the behavioral clues. So I always say it's a change in someone's baseline behavior, their actions or their mood. I hate using the word normal because, again, normal doesn't really exist, right? We're all so unique. So it's really about someone's change in baseline behavior. And so that leads us to a little mini activity that I would like to do with you all. As we are a little research focused here, I'm going to be using you all as experts in the room, and we're going to be creating a resource about clues and warning signs that we see within our different age groups. So from elementary, middle, and high school. So think of it kind of as a focus group activity. So this might be something that many of you all are familiar with. I got to, get to know this new resource here, and it's called Padlet. And what we're going to do is we're going to collectively add some clues and warning signs. We're going to start with our verbal clues, and we're going to categorize everything. So I will share a QR code on the screen that you will scan. But what will pop up is when you go and add a post-it, type in your clue and warning sign that you're aware of based on the age groups that you work with under those categories and select the group. So again, we're going to start off with our verbal clues. So really think about those themes of statements where an elementary schooler, right, our kindergarten through fifth grade, may make a statement about feeling alone, like a burden. Same with middle school or high school. And this is to just bring us aware of the different approaches to language that our kids use, right? Because a elementary schooler's vocabulary is going to be drastically different than a high schooler's. So what I'm going to do now is I'm going to put that QR code on the screen. You can also click the link here and take a moment to log on, get familiar with Padlet. And then what I'm going to have us do is we're going to switch screens and we're going to start looking at that resource that we're all building together.
I also put the link to the Padlet in the chat there. If you want to use your phone or your laptop, whichever one works best for you.
I feel like we need like the Jeopardy theme song a little bit during this like in between time, but I'm not gonna hurt anyone's ears with my singing.
It looks like most folks have gotten in, so I'm going to switch to share my screen so we can kind of see some of these answers as they're coming up.
Yeah, just like what Dr. Rogers said, when you think about our elementary schoolers, they're saying like my stomach hurts, right? Some of those somatic symptoms, not wanting to play, no one likes me, that feeling of isolation, right? Because getting along with their peers is such an important protective factor too, that sense of belonging. I
Wish I
wish I
wasn't
wasn't
born. Yeah.
born. Oh,
Nothing is going to work. That's
no
the
one
worst.
loves me. Wow. So very different, right? When we think about how we may communicate our feelings. We'll take a look through our middle school age group here. I'm done. I don't want to be here. I hate my life. Negative comments about self in school.
I don't want to feel this way anymore. I think that's an important one too.
Mhm. I don't care.
I'm gonna go through our high school now, and we did leave the option open if you wanted to comment on other people's or upvote them, so we have an idea if you're seeing something that resonates with you as well, or with what you've seen your students.
Oh, this is my 13th
Mm,
reason. Thinking about some of those topics that might be age specific, right? With what's on TV, what they're viewing at home, texting
that
friends.
I think that's a big one is that texting friends or posting on social media. Some of those at the time might seem sort of cryptic reposts of a TikTok, but then you're like, oh, that doesn't sit right. I've had experiences when I was working in a school of friends coming up and showing me things that their friend posted, just saying like this is out of character. I'm worried. So I think that could be that is a glimpse into their life. Yeah. Just want to
Yeah, yeah,
disappear.
I mean, those indirect clues are tough. There's when we teach QPR, we teach people to ease their way into the conversation, sometimes saying things like, hey, when people are going through what you're going through, they may have thoughts about killing themselves. But if you flip it, those that are thinking about killing themselves may use that same tactic, which is, hey, look at this TikTok or look what so and
Mhm.
so said, right? And not say, hey, I'm feeling that way, but just highlighting it to test the response, right? Let me see what mom says when I point this TikTok out, or let me see what my friends say if I forward this, or so
Yeah.
something to certainly something to take into consideration when screening kids.
Yeah. So it seems like our answers are slowing down here, so I'm going to stop sharing. But we will compile all of this information and send it out to you all afterwards, so we have a living document. And this, I'm going to leave the Padlets open, probably till later this afternoon. So if you think of something later or something comes up, you can always revisit these.
Awesome. Thank you all for participating. Again, I think this is going to be a very valuable resource for everyone participating, and even myself. I really appreciate your viewpoints. So now let's get into our situational clues and warning signs. So again, this is our invisible backpack, right? So think about those important, impactful events that are occurring in their lives. One example might be the loss of a parent, right? Unexpectedly at a young age. That could certainly have an influence. So really think about for this next Padlet activity for our clues and warning signs. What are those big life events that are potentially occurring in elementary school, middle school, and high school? So we kind of talked about graduation, we talked about the loss of a parent, like what is happening during that age group. And we can even talk about some bullying too that may occur. So I'm going to go into our next slide for our QR code. Go ahead and either click the link that Kate has dropped in the chat or use your phones to scan the QR code. And let's start collaborating together on what those situational clues might be. What are those important, impactful events that are happening for our elementary schoolers, for our middle schoolers, and then lastly for our high schoolers?
I just saw somebody in the chat asked a question about one idea at a time or all on one sticky. I don't really have a preference. Whatever makes the most sense for you to organize your thoughts is totally fine. And it looks
Yep.
like most people have had access to this. So I'm going to move over to sharing so we can look at the answers as they're coming in.
And Kate and I will make it pretty before we send it out. So don't worry about some of those little nuances. So we see like problems with peers, right? Because we know that peer-to-peer is very important in that age group. Hospitalization of a parent for mental health. Moving is a really good example, right? Because when we think about their friends, right? Moving away, not really understanding why they have to move either. We have divorce, right? So a lot of questions up in the air with what that may look like in their lives. The loss of a pet, right? Our pets are our families, right?
I see a lot of that, the idea of loss, whether it's a pet, a parent, an adult, or a teacher in their lives. And I think at that loss is always hard, but particularly at that younger age to understand the why. And it can be easy for um, kids to blame themselves. It's easier for adults than blame themselves for things. It's especially easy for kids.
And it might be the first time they're experiencing loss too.
Mhm. I'm going to move over to our middle school, and I see that some of these they do cross the age groups. It may look and feel a little bit different, but I see, there's peer conflict in some way across all of these age groups, and I think that is such an important piece to consider.
It's a big theme overall because that affects all of us, right? Even if we're adults in the workplace too, or with our friends.
I've seen not making a sports team or being kicked off the sports team come up several times. Um, and Steve, you may know this better than I do off the top of my head, but I know that male athletes, particularly white male athletes in our state, are a group that we've seen that is at higher risk for suicide. Maybe higher risk is the wrong phrase to use, but the data has shown that we have had several high school males, predominantly white, who were kicked off the sports team, lost that privilege for some reason, and then afterwards did end up dying by suicide.
Yeah, I mean, and regardless, I think of race, we just have a larger white population, so that's why it's
True.
probably more prevalent. But regardless of race, yeah, those type of events certainly can be devastating for what you would consider sort of pro youth athletes in a sense, at least in their minds, that everything is resting on their athletic accomplishments. So certainly would have a huge impact on lots of these kids. So
And when I'm done sharing my screen, I'll put in the chat. So the CIAC, the Connecticut Interscholastic Athletic Conference, I believe it stands for, they did put together a mental health and well-being curriculum specifically for student athletes. And I'll share that in the chat as well.
yeah, that's great. And that's where screening can occur as well.
Mhm.
Yeah, so we in fact, speaking of the Columbia, they repackaged. It was a funny move. It's the same screener, but they put titles on them. And so they labeled one for coaches, but they labeled one for teachers, they labeled one for healthcare professionals, but it's all the same screener. It's just the same questions repackaged, but making hope. I think the hope was to make people more comfortable thinking that it was focused on them.
That makes sense. Yeah. All right, I'm going to stop share because I think we're slowing down, but a lot of that same, I see college acceptance and rejection for high school,
Oh yeah.
that idea of moving on. Um, particularly not knowing what you're doing next, that disconnection from what was your sort of safety net in a high school, once you move on, can be difficult for students. We've seen that for sure.
All right. Thank you all again for sharing those with us. So last one, our last activity here, thinking about behavioral clues, right? So again, thinking about changes in mood or baseline behavior. Again, recognizing that there's really, normal is a bit of an outdated word, right? Because we all can have ups and downs through our days, but let's think about for behaviors for elementary school, for middle school, and for high schoolers. And go ahead and scan that QR code or click the link that Kate has put in the chat. And let's start putting our brains together to think about what are some of those behavioral clues that we may see in these different age groups.
All right, Kristen, I can see folks are answering, so I'm going to switch us over. Again, I saw someone in here about whether these Padlets will be shared. We will share the results. We can also add the link to the Padlets themselves when ready to share it out widely. I am going to lock it just to make sure that, if this is distributed, that other folks aren't adding things that may not be appropriate to it. But you will have access to the information for sure. So right off the bat, looking across the age groups, I'm seeing a lot of that acting withdrawn, playing alone, isolation, going quiet.
Yeah, a lot of that withdrawal, right? Like purposeful isolation, right?
I'm sure poor attendance is a pretty high risk flag.
That is something that we do look at when we receive notification for a student who's passed away by suicide. We often do look at the attendance as well. Kristen, it looks someone is asking to share the barcode again. Are you able to copy and paste that into the chat? If I do that, it'll navigate us away.
Yeah, let me try. Let me give it okay, I'm gonna try putting it in the chat. And I'm gonna send it to everybody.
We're seeing those somatic complaints. Dr. Rogers, you were talking about seeing that as well.
Yeah, for
I think
sure. For our school nurses, I'm 100% sure they are very familiar with that
mhm.
15-year-old female who has been coming in, every other day with abdominal pain, abdominal cramps. I'm tired. I have headaches. And certainly those are excellent opportunities to screen kids. Um, especially if it seems to be new onset
Mhm.
and persistent.
Yeah, I think folks are making a good point here because we do see that isolation and that being quiet, but then we also can see the opposite, that sort of lashing out, acting out, some of more of the aggressive behaviors that weren't there before. I think is another thing to look for as well. I'm wondering if you folks need the, can I do this? There's the QR code really quick if anybody needs it. I don't know if I can. Oops, I was going to try and copy and paste it, but if anyone needs a QR code, again, it's right there. I'm going to close that. Shutting down social media posts again, we're seeing some of that. It's for our high schoolers with drawing, skipping classes.
Low energy,
Mhm.
that's a big one. Giving
Giving.
away things, yeah.
And when Chris and I were planning this and talking about it, like giving away things kind of made me think of this. This could be occurring in spaces that we aren't aware of, right? Like what's it? And I will admit that I am not a gamer or really up on video game culture, but I know that a lot of our students spend a lot of time playing online. And so what might that look like in a video game setting, right? Are they I don't know, giving up the cache of weapons that they have accrued over 2 years, playing cooperatively with friends, or are they, all of a sudden deleting a character, right? So things like that we might not know about, but could be occurring. So if anyone has any insights into things like that, we'd love to hear those as well. But just something to keep your eye on, and also something to when you're talking with students about it, they may have information that we're not aware of, because it's happening on these other platforms.
I like the unkept appearance as well with personal hygiene. Again, we've all had a bad hair day every now and then, but going to that next level of maybe they're not brushing their teeth, you know, taking a shower regularly, things like that that you notice.
Yeah. All right. I am going to stop sharing. Just notice we're at 10 o'clock now, and I know we've got a lot of good information to get through as well. But thank you all for sharing this and for participating in this sort of group
Yeah,
think
this
about
was
what
great.
this might look like. Yeah. And we will, again,
Yeah.
we'll share this all with you.
All right, so just to wrap up some of our last programs that we have here at our Youth Suicide Prevention Center is our Fresh Check Day program that was developed by the Jordan Porco Foundation. So Fresh Check Day, it's a mental health
Kristen,
fair.
I think Kristen, I think you're in presenter mode. That's I think that's better.
Let me try again. How about now?
Getting there. Better.
Okay, awesome. Thank you. So Fresh Check Day, it's a mental health fair. It's a peer-to-peer framework. So again, we very much so saw that in our clues and warning signs that we discussed earlier, how important it is to be engaging with their peers and those around them. So this program can be adapted for schools, communities, and workspaces. And so what it does, it encourages help-seeking behavior, connecting resources, local resources, or internal resources. And it also promotes positive coping strategies and wellness habits. And I would like to briefly draw your attention to the photo below. So at Connecticut Children's, we are hosting our version of Fresh Check Day that's adapted for our environment here, that we have patients, families, and team members being involved. And yes, that is me dressed as a pickle. And so what we do again is just to really embrace these conversations, get people talking about their mental health. And when you encounter a positive pickle, it really kind of takes that armor away, right? It's not so scary to start bringing in those conversations. And so we do this whole theme around mental health and wellness by creating these atmospheres. And then in addition, again, just a little bit more about this program. You can adapt it as a lunch and learn model. You can do one booth per day. We have a number of different booth options that you can choose from that may resonate with your communities, your school settings, the populations that you work with for ongoing engagement. So We've been running 4 booths every Wednesday throughout the month of May, and we are really hoping to reduce the stigma, create that culture within our hospital system that, we are promoting mental health and well-being and really getting people to start talking about it. So our surveys, we found that 87% were more aware of mental health resources, 83% more willing to ask for help if needed, and 82% more comfortable talking about mental health. I will just say from participating, it's been amazing to hear those brave stories that our team members and our participants have been willing to share with us. Lastly, we'll go to resources, and I'm going to hand it off to Dr. Rogers to briefly go through with these.
So there's a question in the chat. What kind of things are presented at these booths?
Sure. So we have one booth that's called It Takes a Village. And that's where we house all of our resources. So the ones that are available within our communities or internally at our hospital for team members and patients and families. We have another one that's called 100 Reasons. And we create this visual tree where everyone writes on a leaf. And at the very end, we have this beautiful blooming tree with all these messages of hope and kindness and just positivity. And then every time we host the event, we keep that tree up so people who walk by throughout the month can see it blooming over time. And then last, as an example that we have is our Mood Matters, which is a friendship making booth. And I'm actually wearing all my friendship bracelets right now, where we talk about different mood disorders, things like depression, anxiety, and just destigmatizing those topics, saying it's okay to have a day where you're not feeling so great. But let's do a activity that really gets you in a better headspace and kind of takes you away from the hustle and bustle. So those are some examples that we've shared so far.
Yeah, the basic principle is they're peer designed and peer run booths, or in a high school, you'd have staff obviously running some of the booths as well. And the engagement point is something fun like a friendship bracelet, but it creates an opportunity for them to say, oh, and did you know that you can come to your counselor for this and this and this? And have you had any problems lately? Some of our college booths even actually have counseling services that screen people during the actual fair. And most of them we will have like any other kind of fair where you can get stamps, and if you collect all the stamps, you get put in a raffle, and you can win T-shirts or flat screen TVs or all sorts of fun stuff. So it's really to get people engaged and just thinking about it in a positive, open way. But jumping into resources, I will say again, I don't know how we got right to access mental health. Did we skip ahead?
We reordered them a little bit just to make it
Okay.
flow. So we've got Amy,
Oh, that makes sense.
Emily, and
Okay.
then Amy are going after this. So
Okay, cool. We are very lucky here in Connecticut. We are resource rich. We definitely, um, in my mind and opinion, have no excuse to not screen. We can't say, oh, I can't screen because I don't have X, Y, or Z. Oh, I'm not going to ask because I won't be able to respond. We can respond. So our pediatricians are equipped with something called Access Mental Health. That's basically an on-call psychiatrist for them to use as a resource when managing kids with mental health disorders. So we should have very little hesitation to, at a minimum, refer our patients, or in your case, your students, to their pediatrician for support, especially if they're already, for example, on medication or have had a history of struggling with thoughts of suicide. So that's just one thing for you guys to be aware of. And that may be something that your school health programs can access as well. If they sign up, they can get that support. So next slide. I think we can probably skip through some of these. Oh, and they support kids up to 22. So no problem with high school kids, obviously. Next slide. The other one, awesome for our younger students, Gizmo's Possum Guide. They can get a free book. Hopefully, you guys have a couple copies in your library. If you don't, I would recommend getting them there. It's a fun, interactive book with this cute little dog and the dog's friends. And I have a beagle, and there's a beagle on there, so that makes it really good. But it's really it's like a parent's guide to how to talk about mental health. It's really simple, but I learned from it. Just looking through it, like, oh, that's a great way to talk about that. And it's a workbook, so they can actually write in it. They can identify trusted resources, trusted adults, things like that, that I never really thought of doing with my own kids. Like, I assumed I was their trusted adult, but that may not be the case. Um, and how nice would it be to know as a parent that your Uncle Bob is the trusted adult, and you have an agreement that they can go to him for anything they want. So very good guide, and it was designed right here in Connecticut. And there's a push right now to push it out nationally. So definitely something to check out. Next slide.
And
Yes,
and
it's
this
in
is one
Spanish
of
as
our
well.
yeah, and we hand out these books during our wellness events throughout the month of May, and they've been a hit. It's really cute watching the kids get so excited about the cute dog on the cover, and then skipping out the door. Just very, it's a very positive moment.
It also comes with a contract for the adults, just saying that they're going to check in on their child's mental health on a regular basis, if that's something that would be useful for you guys. And then obviously we have 988, so anybody can access 988 resources at any time, and that is interconnected with 211, which is our local hotline for resources with a wide range of available supports, but definitely interconnected so that they can support anybody that's calling in with risk of suicide. Next slide.
I'm actually going to hand it over for
Oh,
our
okay.
next speaker.
I will transition to our mobile crisis and our urgent crisis centers just by saying I'm going to let them introduce their services, but I want to endorse them and their partnership in creating what I think is the closest we've come to an actual system with different levels of care appropriate for different kids and different needs. The ER is not the right place for everybody, but it is for some, as we saw in that Columbia results. Remember that big messy graph with all the red and the orange and the yellow? We are the red. When we have a child that is acutely or high risk for suicide, we are the place that can keep them safe until we identify the right inpatient resources for them. So we welcome those patients. What we don't want is the 7-year-old who we call the pencil thrower said, I'd rather just die, and throws a pencil at somebody. And we don't want to stigmatize younger children or traumatize them in our environment. It is a locked unit. It is not necessarily the most pleasant environment because we have to keep it safe. We're here for anybody who's at acute risk for sure. We discharge about a third to two-thirds of our patients back home. And so we're trying to reduce that number. And by utilizing mobile crisis as a frontline service that I will push again is 24 hours a day, 7 days a week now. So we really have no excuse not to engage them and promote them for our families who may be struggling when they pick up their child from school and take them home. Knowing they have that resource to turn to, I think is huge and should be reassuring for you to know that, okay, I just gave them an excellent resource that can help them, guide them when I'm not available. And then the urgent crisis centers are amazing. They're built for mental health. They're pleasant environments. They're less threatening. They're not necessarily locked like ours is. And they have a full array of staff that do amazing work and really have diverted so many kids from the ED. It's awesome. So I will be quiet and let them talk about the amazing work that they're doing.
Okay, Emily, I'm going to hand it over to you. Just let me know when you're ready for me to switch sides.
Okay, thank you so much. Thank you, Dr. Rogers. Good morning, everybody. I am Emily Conkey. I'm the Associate Director for mobile crisis intervention services here at Wheeler Clinic. Um, as Dr. Rogers was talking, in the state of Connecticut, we have this amazing service that I'm sure you are all hopefully familiar with. There are 6 agencies in the state of Connecticut that provide mobile crisis services. I am just one of them. We do have the biggest range in the state. We service 18 towns. We are in the Meriden, Wallingford area, Hartford, West Hartford area, then the New Britain, Southington, Bristol, all of the surrounding there area. So when we present on mobile crisis, right, we are a 100% DCF funded program. Part of our contract with DCF is that we do outreaches. And a lot of the times we do outreaches to schools and school staff. But today, right, most of you here are well versed in us. But if there is even just one new thing, right, that I mention, talk about, etc., it is exactly why we do this and present to all different types of groups around the state to continue to get the message out about our services and how helpful and supportive we can be, because we have been put in place specifically to be a hospital diversion program, right? To be able to offer and support services to children at home in the community and not have to go to those locked units in the ER. Of course, some kids are absolutely appropriate and need to go to the hospital, right? But we're here to do what we can to support them and stabilize in the community. All right, Kate, you can go to the next one. All right. Um, excuse me. So, youth mobile crisis. We are here for children and adolescents experiencing a behavioral health, excuse me, I'm so sorry, a behavioral or mental health crises, right? We absolutely here at MCIS do not define a crisis. We are not going to turn anyone away. There is no specific definition for crisis that we use, that you should even use, right? If it's a crisis to you, if it's a crisis to the caller that's calling us, then it is a crisis and we will absolutely respond out. As Dr. Rogers said, in 2023, all mobile crisis teams in the state of Connecticut have gone to 24/7 service. As you can imagine, our call volume is a lot less overnight. All 6 of the agencies do work a little differently with how they staff their agencies overnight. But regardless of what time you call, when you call through 211 and it's patched to the local catchment area, you will speak to a clinician that is able to respond out into the community regardless of the time of day. We are super proud of that as well, and being able to staff it as well. All right, Kate. All right, so who provides mobile crisis services? All of our staff, all of our clinicians are graduate level, excuse me, I'm so sorry. Graduate level clinicians. So, right, when I talk about things and when we talk about anything in this field, medically or clinically, is everybody has a different abbreviation past their name, right? So we do employ social workers, marriage and family therapists, alcohol and drug counselors, professional counselors. We do hire at an associate level. So we do hire clinicians right out of grad school and give them on the job training. We also do hire fully licensed staff as well. But that is who makes up our staff. We do have bachelor's level staff who work as our counselors, and a triage staff who are our phone, excuse me, phone specialists. So big, huge crew of people that are here to answer the phone, no matter what time it rings, and respond out into the community. Okay, Kate, go to the next one. So who can access mobile crisis services, right? The state, our wonderful state, has set up things across the lifespan, right? So we have birth to 3 services that services children up until 3 years old, and then we take over, right? So we are from age 3 on up until 18. So we are able to support 18-year-olds as long as they're still in high school. If they are graduated from high school, that is adult mobile crisis, but we are able to support 18-year-olds if they're still in high school full time. Okay.
Can I ask
So
a point of clarification? Because I've heard
yes,
different things about this. So if an 18-year-old is in high school and calls from home, can they go mobile, youth mobile, or is that adult mobile?
yes, no, it
Okay,
doesn't matter
perfect.
where they are. I'm so sorry. I'm getting over a cold and it just my voice goes in and out. It doesn't matter where they're located, Kate. It's just if they're still in school. If they're not, then it is a completely adult mobile crisis. So, who can call us? Anyone that encounters a youth in crisis. So, social workers, teachers, parents, community workers, but even the youth themselves, right? We have the 988 line, which is national, but as Dr. Rogers says, 211 is the state of Connecticut thing. So, the children themselves are able to call 211 or 988 as well, and they do, and we do see that quite often, actually. Our services are completely voluntary, so we work off of the consent of guardians. So with the schools, because we have this direct collaboration with the school systems in the state of Connecticut, we are able to work off of implied consent, right? I have 2 children. I send them off to school, right? I am giving them implied consent to take care of an emergency if and when it happens, right? So and that means another provider, mobile crisis provider, can come and start to assess my child without my consent until I give it, right? So if I decline services, then right at that moment, our mobile crisis staff need to stop what they're doing and we end our services. There's a variety of reasons why people decline us, and that is certainly okay. But we are completely voluntary. So we absolutely do need, and with children being underage, we do need parents present. If we are out in the community or we are at a home, we do need a guardian present. But at a school, as long as we're with other adults and we have that parental permission at some point, we are able to complete a full assessment with that child. How do we access mobile crisis services? Hopefully, all know this, right? 211, option 1, then 1. Also through 988. 211 is our call service. So all of the calls are coming in through there. When you say where you're calling from, then they look at their big, huge map that they have in the state of our huge state of Connecticut, and figure out which agency to call, and then they call our agency directly. Okay. Where do you go to receive mobile crisis services? Our staff will respond to wherever the identified child is in crisis at the time of the call or wherever it may be requested, right? So we have gone to grocery stores before. We have gone to retail stores before. We have met in parking lots. All over the place. We've met at libraries, of course, the school systems, that is our number one caller, homes, et cetera, et cetera. Wherever we can safely meet with a child, that is what we'll do. Who is appropriate for 211 services? Any child that you believe to be in crisis. This includes, but is not limited to, self-harm, suicidal, homicidal ideations, disruptive, unsafe behaviors at school or home, anxiety and depressive symptoms, anything else, like I said before, that you define, the caller defines as a crisis, that's who is appropriate for our services.
Emily, I just want to be, because we're getting short on time here, and I see a couple questions coming up a lot, and this comes up a lot when we talk about mobile crisis,
Yes.
is the idea of parental or caregiver consent, and what mobile crisis can offer when that is not given.
Right. So if we are declined, right? So if the parents decline our services, then we need to stop talking immediately to that child. We can offer consultative services to the school system, right, in that moment, if need be. But that is about it. When we're talking specifically about a child, we are unable to speak about that child anymore after parents decline us. So I see
Yeah,
that.
but Emily, I wanted to highlight, sorry to interrupt, that some of the questions were specific to needing
Implied
verbal
consent.
or needing verbal consent from the parents to engage with 211 services, which is not true. So
No,
the school can engage with the services that you guys provide before talking to a parent. But once you guys are on site, you guys will seek out parental consent. And if it's declined, it's declined. If it's not, then obviously you'll continue.
correct.
Yep.
Correct. So that's why I like to give, it's just easier, I guess, from the medical side, right? So if I send my son to school, right, and
Yep.
he gets hurt on the playground, I, as a parent, am giving my implied consent for you to take care of my child, even if you cannot get a hold of me, right? So you're
Yep.
going to do the necessary things, call 911, send my child to the hospital if need be, even if you can't get a hold of me, right?
Yeah.
So
Yeah. It's exactly like calling an ambulance. So
exactly.
calling 211 is an ambulance without the bus and the sirens.
Correct. So we appreciate when the school systems do call the parents to let them know that this is happening, right? Um, but we will also call to make sure that we have that if we hear that we don't have um consent from the family. But yes, we are, based on implied consent, we are able to start an assessment with a child until the parents are able to get a hold of. So
And
Yeah.
I
I
see
mean,
there are a lot of, oh,
in an ideal world, you would initiate both at the same time, right? Because
correct.
at a minimum, as a school staff person, I would want to have one of the mobile crisis staff standing right next to me or behind me when dealing with an out of control child or one that's not safe, so that I had an expert standing there guiding my response, and helping me decide, okay, is this a 911 call? Or I'm hoping I'm leading into urgent crisis centers because I know we're running out of time. Or can I send this kid to the urgent crisis center? And the answer is yes, if they're not if they need to be transferred out. So I'm going to hand the mic over really
yeah.
quickly.
And real quick, I see folks looking for some wording or some language because I understand and know that what is said here is not always the experience when you call mobile crisis. I'm going to reach out to my colleague at DCF who oversees mobile crisis to see if we can get some language or that if she'd be comfortable putting something together that I can share with you all so you can say, this is what we've been told, and if that would be helpful. So, okay, on to you, Amy.
Okay, Kate, just for a time check, do I have like 10 minutes? How quick do I have to
So
talk?
technically two. We're running
Oh,
really short. But if folks want to
okay.
stay on and they have the time, you're more than welcome to stay with us for this last bit. Any questions that come up, I can also share those answers afterwards.
All right. Well, in 2 minutes, the urgent crisis centers are a brand new level of care. By the way, I'm Amy. My information's on the PowerPoint slide. So call me for all of this. I'm happy to do one-on-one calls to explain what the UCCs are in less than 2 minutes or more than 2 minutes. So the urgent crisis centers are a brand new level of care in the state of Connecticut. We were created really after COVID. We've been around for 3 years. My hope is that many of you, or the majority of you, have heard of the UCCs or have sent kids to the UCCs and hopefully had a good experience. There's 3 urgent crisis centers in the state of Connecticut. We're one of them. I'm from the Village, so we are in the Hartford area. There's one in Waterbury with Wellmore, and there's one in New London with CFA, Child and Family Agency. We all work together. The UCCs are not limited to the region, meaning you don't have to be in the Hartford area to come to the Village. We actually service kids as far out. Well, we've serviced kids in Massachusetts. We've had kids in Stamford. So if families are willing to drive, we are available to all kids. We can go through this, move on, I guess, Kate, from this slide. I really want to talk about why this level of care got inserted in the state of Connecticut. So you have sort of your hospital level of care, as Dr. Rogers said, right? And there's a place to go for those kids in need. That's your highest level of care kids who need inpatient level of care. The UCCs were designed just like mobile crisis as a deterrent to the EDs. You can keep going through some of these slides, Kate. But so they're right below an inpatient level of care. So if you look at kids in crisis, again, they define crisis just like Emily said, and we are a place to go. We are 7 days a week, 7 in the morning till 11 p.m. and on the weekends 10 to 6. It's a walk-in level of care. When we built this level of care, again, right lower than an ED, we have a complement of an interdisciplinary staff. And we do basically, I think, what you would get in an ED from a behavioral health crisis. We provide triage level of intervention. We provide an interdisciplinary, very comprehensive level of an assessment, de-escalation, work with the child. We also obviously develop an intensive crisis safety plan and return the kid back to the community with their family. We work with the family. We don't treat the child in a vacuum. We believe in a much more comprehensive family systems approach. We believe if a kid's in crisis, the family's in crisis, kids in crisis. So it's this holistic work with the child and the family. There's also aftercare services, which I think make us really unique in the state of Connecticut. So we follow families for up to 30 days post-discharge. So we will call the family daily, weekly, depending on what the needs are. And we hold that family until that next level of care has started. We do the bridging, we do the follow-up. In most cases, the family doesn't leave us until we have an appointment set for them. We also, take kids in high level of crisis versus low level of crisis. We talk about doors. While you can go to any door, whether you can call mobile crisis or go to the local ED, we would rather, not that you don't have to come from mobile crisis, but as far as going to the ED or us, we would prefer you start with us, let us figure out if we can meet your needs. And if we cannot, we have warm handoffs and a good relationship with Dr. Rogers and his team, where we will do a transfer to the local ED or to CCMC. That's a lot in a nutshell. Ambulance, we do take ambulance. 911 if 911's called, or if 211's called at your local school. Please know that you can recommend the urgent crisis center instead of the ED. We have done lots of trainings with EMS providers, but there's a lot of turnover, and the smaller ones might not necessarily know of us. But ultimately, it is up to the EMS team to decide whether they're going to take the child to the local UCC. I know there's sometimes some conflict there. Go ahead,
Yeah,
Dr.
Amy,
Rogers.
I want to reemphasize that. Somebody just said they've had good experiences getting them there, and that obviously the UCCs are very receptive. Our EMS personnel are high. Well, I won't say easily, but are definitely can be influenced or encouraged to utilize the UCCs. I don't think they necessarily are knee-jerk using them yet. I think they're set in some of their old habits, and it has, even by data and other places in the country, it takes years to really reset some of that thought process. So we're really, really hoping you guys can encourage them. As Amy said, there's no wrong door. They can take a high-risk patient there. They can patch in and talk to them before they arrive and make that decision together. And if that patient's not appropriate, they can, Amy and her staff can send them to us, and we'll take care of it from there. But they just have a much better chance of going home with wraparound services as opposed to waiting in our ED for a long period of time.
Thanks, Dr. Rogers. Kate, I don't know if you want to just show some of the pictures, because that will really, when we created the UCCs, we really created it from a holistic perspective. And that included not just our staff, right, our team, which you would have said in that slide, an environment of care, our partnership with our team members. But this is really about the environment. And as you look through some of those pictures, you'll see that we have intentional space to manage different levels of kids. So you might have, what we call our sensory room, which is for higher level of kids who might need more space, more physical interventions. We have patting on the walls if they have, incidents of aggression, or that helps with the sensory, sort of grounding them from a sensory perspective. So we really intentionally thought about our space to manage the different kids. As far as some data, just so everybody knows, we've seen since we've started just in our location alone over 1,800 kids. 94% of those kids approximately will return back to the community. So only about 6% of those kids end up going to Dr. Rogers and his team. We look at it as an ED diversion. So about 64% of the families indicate they would have gone to the EDs if the UCCs weren't in existence. So we really feel like we're meeting that level that Dr. Rogers is talking about. But the more kids that continue to go to the ED and end up going back home, those are the kids that we want to continue to target to ensure that, we get the right kids in the EDs and the right kids in the right doors. Again, the interdisciplinary team is super, super important because we are that next level down. So you have an interdisciplinary team that consists of psychiatric personnel, registered behavioral health nurses, clinicians, behavioral support staff, and family support staff, as well as discharge planners. So it's a comprehensive interdisciplinary team that can really meet the needs of the families. I know there's a slide somewhere in there that will talk about what just some information to know. When families and kids come to us, it takes an average of 3.5 hours, 3.5 to 4.5 hours. Obviously, there's outliers on both sides. That's really important when you tell families to come to us so that they're aware of the entire process. We do bill insurance, but it's not a barrier to care. We do want to continue to advocate for EMS transport. And obviously, it's a walk-in, just like the ED is. You do not need an appointment. We do have families that will call and say, is there a wait list? Can we come? We have a main number. I do always recommend, if staff are concerned whether they should be calling us or somebody else, the main number is on here. Call us. Ask to speak with a charge nurse. Talk through your situation, and we're happy to partner with you. So that is super fast about the UCCs, but again, all my information is there. Please, call or email.
Thank you so much. A couple questions. So there's about in the whether or not there's a UCC in the New Haven area. So Yale is okay. You can go ahead. You know better than me.
Yeah, no. So there was 4 that was created. We call the 3 community ones. I left out Yale intentionally because it's not really a community UCCs. They do have what's called a crisis intervention center, which is a CIC, which is a new level, a model that they utilize in their ED. That is opening in the next, I think, a couple of months, but that will be located in their ED, but it's not like the UCC. But we're hoping to build more. We constantly asking to go down in that area too. Sorry, Kate, any other questions that I missed?
There's questions about, and this comes up all the time, EMS and ambulance transporting. I think it is tricky because there are different EMS providers throughout the state.
There's 126 EMS providers in the state of Connecticut. That's a lot. The local ones, we have bigger ones where they'll come further. We do know that local ones, so like when we work with Manchester, for example, they have a bigger one that works with them, and then they have their local one that works with them. The local one is less likely to transport all the way here, but I do argue, and I will always say this to EMS, if you're willing to transport to CCMC, you should be willing to transport to us. So with the distance shouldn't really matter because we're not far from the hospital.
Thank you so much. And I put in the chat before, here are the QR codes for the continuing education credit request form and the course evaluation. Thank you to all who are staying around a little longer. I saw there was some an ask for contact info for the different UCCs. I am going to drop right now in the chat the Urgent Crisis Center flyer that has the different information as well. So thank you again all for joining us. Thank you to our knowledgeable and wonderful presenters. I'm going to go through the Q&A and pull out some questions, some themes for questions, and hopefully get answers for those for you all and share that information when I share the slides with participants. That will, in full transparency, probably not be until Tuesday or Wednesday of next week. So thank you again all for joining us. And thank you to those of us who've been joining the Student Support Series throughout the year. It really means so much to have such a wonderful community supporting our students and also seeking out and taking advantage of these professional learning opportunities. It's been a really meaningful experience. So thank you all so much. Um, and I know there's some issues with the Zoom link, and Craig and I from CERC, we're going to be working on that over the summer for next year. So thank you again, everyone. I really appreciate it. And enjoy your upcoming long weekend. And thank you. And please have a as calm as possible last month or so of school. I know we're in the it's the sprint to the finish line now. So take care, everybody. I will put the CEU link in the chat again right now.